Welcome back to the Art of Cerclage. In this video, we will discuss counseling patients about vaginally placed cerclages. The learning objectives for this video include summarizing the risks, benefits, and alternatives of cerclage placement to a patient, discussing important planning for the operating room, and formulating a treatment plan after cerclage placement. As you can imagine, counseling a patient changes based on the indication for the vaginally placed cerclage. Here, we're going to be talking about history indicated versus physical exam or ultrasound indicated. For history indications, we can discuss with the patient how the cervix has problems keeping the pregnancy inside of the uterus, and how a cerclage, or a stitch around the cervix, can help keep the cervix closed even when there's increased pressure from the pregnancy. An alternative to this surgery would be to watch the cervix closely, possibly with serial transvaginal ultrasounds to measure cervical lengths. For physical exam or ultrasound indications, it helps to explain to the patient that we've detected, either by exam or ultrasound, that the cervix is starting to shorten and open. This increases the likelihood of spontaneous dilation and possible fetal loss. One option is to place a cerclage to prevent further shortening and dilation of the cervix. Another option is to watch and wait, expectant management. This is a difficult conversation and decision for patients, and sometimes having discussions with the NICU is helpful so that patients better understand the situation and the possible outcomes of a pre-viable versus a preterm delivery. In addition to the indications and the alternatives, it's important to discuss the possible risks of the procedure with the patient. Notable risks include infection, bleeding, labor, rupture of membranes, all of which can result in the loss of the pregnancy. And since cerclage placement is a surgery, there is risk, although low, of damaging surrounding structures like the bladder, vagina, or rectum. It's also important to counsel patients that all of these risks are higher with cerclages that are placed in later trimesters, notably the physical exam and ultrasound indicated cerclages. For example, if the membranes are exposed, it's easier to accidentally rupture the amniotic sac. If you and the patient have decided to move forward with a cerclage placement, it's important to discuss the operation and surgical planning. We should remind our patients to not eat or drink at least 8 hours prior to the surgery. They may have to wait longer for anesthesia if they accidentally eat breakfast or coffee with milk on the day of the surgery. It's also important to set expectations. Majority of patients go home on the same day of the procedure, but some patients may stay overnight for observation. Patients will be worried about the status of the fetus. You can reassure them that the fetal heartbeat is monitored before and after the surgery. For the procedure, we usually recommend spinal anesthesia. This is when a medicine is injected into the cerebral spinal fluid of the lumbar spine to anesthetize the nerves that exit the spinal cord. This is similar to what patients receive in labor or for a cesarean delivery. The anesthesia team on the day of their operation can help answer any questions the patient may have. Additionally, patients should expect some cramping pain that usually is helped by Tylenol and a heating pad. Some providers may prescribe a short term of tocolytics to help with the pain and to prevent contractions, or recommend a short course of NSAIDs or narcotics to help with the pain. Prophylactic antibiotics, like Ancef, and tocolytics, like indomethacin, should be given to patients when the amniotic membranes are exposed and when the risk of contractions that dilate the cervix is high, like in a physical exam indicated cerclage. Rh-negative women may ask if they need to receive RhoGAM after the operation. Cerclage placement is not a potential sensitizing event. Therefore, these patients do not need RhoGAM. However, if there's a complication where there's hemorrhage or fetal loss, Rh-negative women do need RhoGAM to prevent alloimmunization. After surgery, patients should expect to have some soreness and cramping. They may also have some light spotting. It's important to discuss what symptoms would warrant your patient coming back to the hospital for evaluation. Examples include bleeding like a period, severe abdominal pain, fevers, malodorous yellow-green discharge, or loss of fluid. In addition to immediate post-operative care, it's important to discuss modifications for the rest of this pregnancy. Patients with a cerclage in place need to practice strict pelvic rest. This means no intercourse, internal digital stimulation, tampons, etc. Also, because there's a suture in the cervix, the vagina responds by increasing the amount of mucus it produces, so it's normal for patients to have increased discharge. However, if the discharge is yellow, green, malodorous, it's not normal and they should alert you. Additionally, if the patient was receiving transvaginal cervical length screenings before the cerclage was placed, they do not need to continue the screenings after the surgery. Lastly, all vaginally placed cerclages are removed during the current pregnancy at 36 to 37 weeks or earlier if the patient presents in labor. Let's review some important points. Communication is essential when discussing surgical treatment of cervical insufficiency. Informing the patients on all the risks, benefits, and alternatives is vital. Once the patient is committed to cerclage placement, it's important to review all the surgical planning for the day of surgery, as well as immediate and long-term follow-up plans for the patient. It's also critical to educate patients on normal symptoms versus worrisome symptoms. We hope this video was helpful and that you feel more comfortable counseling patients on vaginally placed cerclage. We hope you continue watching the rest of the videos in this series.